Good morning. Thank you all for being here, and thank you for this invitation to beautiful Hawaii. Before I start, I just wanted to get by show of hands, how many are using PI-RADS in everyday clinical practice? Great, awesome. Not everyone though, so I was trying to gauge how much I should go into the details of this. So no financial disclosures. So just to go into a little history, how PI-RADS came about. So, Hawaiian tradition has a lot of storytelling. So it was a cold and dreary night in 2007, Stockholm ISMRM. It started as an ISMRM. So it was the ADMATEC Foundation Working Group that was discussing prostate imaging in general. And the question came up that there was really a need for standardization. That led to a consensus group meeting in the UK, led by the urologist Louise Dickinson, and several of the radiologists came together. Again, the question was really, there needs to be some more standardization in terms of image acquisition, interpretation, reporting, et cetera. And that is what led to the work by the ESUR, which is the European Society of Urogenital Radiology, to start putting something together. And that started in about 2010-11. This was published in 2012. And immediately, just to go over a little bit about what this was, the original PI-RADS version 1 had a 1 to 5 point scale for everything, for T2, for diffusion, for DCE, and spectroscopy was an option included in there. There was an equal role for DCE in that. And there was sector map and et cetera. So what it did, though, was it provided the first step towards standardizing MR, prostate MR. Clinical indications and minimal and optimal imaging acquisition protocols were provided in the originals as well, and a structured reporting system was described. So if all was there, so why was version 2 even needed? But as soon as the one was published, there were clear limitations, because this was something that was put together by a lot of just to try to get something out because there was such a big need. And there was rapid progress, obviously, especially in the area of diffusion imaging. And the idea was to get a single international standard, to have a common language for all to speak, and to simplify, to encourage widespread adoption. So the expectation was always that it was going to be a living document, that as scientific data accrued, that this could be tested, validated, and added to. So it was never supposed to be a one and all done document. And for this, there was a combined effort of the ACR, ESUR, and the ADMATEC. They agreed to collaborate, but it took 4 years. So for version 2 to come out, it took a fair amount of work. And this was published. This was the original 26-page document that anyone can download and see. And then this was a synopsis of the whole. And there was also an editorial by the urologist in the second, and the synopsis. And the best part was this was in a urology journal. So the idea was always to gain the clinician support, and so they were all speaking the same language, not just among radiologists, but also among the clinicians and the radiologists. So in the version 1, the focus was on technique, lesion detection, clinical applications. In 2, it was a combined effort, lesion detection, characterization, interpretation, and reporting, specifically also of benign findings, image illustrations with scoring criteria, and specific measuring and mapping details were included. Lexicon is in there, and Atlas is still at work. It's a work in progress. But the idea was to make this more user-friendly. Idea is to get it out, and so people can use it. So what, in general, the PI-RADS is trying to do is it's a risk assessment, right? So it's trying to assess what is the chance of a clinically significant cancer. And so what is clinically significant? It's described in the document as a score of greater than 7, certain volume, and if there's extraprostatic extension. So those are specific things that we're looking for. And there's an assessment category, and you may have all seen these, from very low, highly unlikely, to very highly unlikely. Now, the problem with this is we don't have any percentages because we don't have enough clinical scientific data yet. As that accrues, that can be added as well. One of the big changes between 1 and 2 was the diffusion. The highest p-value was 1,000. That was included in 1, but it was 1,400 or greater for 2. And the idea is, you can see the dark area, large tumor anteriorly. You can acquire that using a high B value, or you can calculate it. And there's good data now showing that it's the same. And as you can see, if you acquire very high B values, your signal may be distorted and you can get this ghosting artifact, as opposed to the calculated B value that gives you that doesn't give you distortion and equal results. So the criteria in PI-RADS 1 was equal weighting in all, and then of course 2, there's a difference in where the lesion is located. It's all real estate, right? So location is important, and so diffusion dominates in the peripheral zone, T2 dominates in the transition zone, and here the DCE plays a minor role, but I will show you that the minor role is just not for name. It's actually fairly useful, not just for the upgrading, but I'll show you why. And here, MRSI was not included because of the not enough scientific data and the Akron trial not showing much in this arena. So of course, a 5-point scale for T2 and diffusion is still there, and the DCE is only a plus or a minus. And then algorithms and tables to determine overall score, the assessment category. So one of the bigger changes also was the size criteria in the T2 and diffusion to separate PI-RADS 4 versus 5. So if it's greater than 1.5 centimeters, it's a 5. So just quickly going into the PI-RADS T2 in terms of the peripheral zone, it goes from 1 to 5, uniformly hyperintense. And just to go show some examples, nice peripheral zone, it's bright, white, this is a normal 1. And if you go into 2, this is the stuff that you get in home, wet shape, diffuse, mild hypointensity, or you can get linear areas and indistinct margins, and that's a 2. If it's a circumscribed, homogeneous, moderate, hypointense nodule, and this is where the lexicon is very useful, what terms to use, and it gives very good examples and images in the document. And again, 5 is same as 4, but just the size is increased. But there's a little more. So there's also invasive behavior. So it's not just the size of it, but if it's if it's extraprostatic, if it's involving neurovascular bundles, et cetera, it's a 5. Now, what about transition zone? That's where really the problem is still persists. And so this is if you look at this transition zone with multiple nodules everywhere, typical enlarged transition zone BPH, this is a 2. You can have circumscribed nodules, that's a 2, but what about this? This is where you start having problems where there's it's a 3 because it's, I don't know, it's obscured margins. And what I will show you, there are ways to help that, is if you do coronal or sagittal images, look at the borders on that. And I'll go show you some examples about that. This is, on the transition zone, a 5 is same as 4, but it's just enlarged, so greater than 1.5 centimeter. And here's the typical homogeneous, the erased charcoal sign that's been discussed, where you see the transition zone, you lose the architecture, and it's also bulging anteriorly. It can also be lenticular shaped, teardrop shape, et cetera. But you see, this is the normal transition zone, and now you lose it. These are fairly easy. It's the problem is when they're partially obscured, and it becomes a 3. So let's look into diffusion. Diffusion, obviously, 1 is when there's no abnormality. This is bright on ADC, and 1400, you see no bright areas, except for the posteriorly, and you can see that in the region up in the base, you'll see some dark areas on ADC, and that's bright on the high B value. It's the region of the ejaculatory ducts, and that's a normal finding. Now, what about 4? This is where you have the hypointense black and white. So a 4 is easy. It's dark on ADC, very bright on the high B value image. And if it's a 5, obviously, it's bigger than 1.5 centimeters. Now, looking into contrast, what is positive? For contrast to be positive, you have to have an abnormality on the T2 or the diffusion weighted imaging. So here we have a lesion in the peripheral zone, and this is focally enhancing. In the transition zone, here is a mass anteriorly that's bulging the capsule, and it's focally enhancing. So this would be considered a positive on DCE. Now, the problem is, its misunderstanding is that what is negative? So obviously, if there's no lesion on the peripheral zone here, this is negative. But if this was diffusely enhancing as well, that would be a negative. So you have BPH nodules that are enhancing, that's negative. So that's not because you're seeing this enhancement, but these are BPH nodules. Of course, you have to assess with T2 to make sure they are, and then, so that's a negative. So no early enhancement, or there's diffuse enhancement, it's a negative. So now how are these categories assessed? So again, real estate, right? Location, location, location. So peripheral zone, diffusion rules, transition zone, T2 rules. And so we have a score of 1 to 5. If it's a score of 3 in the peripheral zone, which is the intermediate category where I don't know, and the DCE is positive, it can be upgraded to a 4. Now, not so much helpful in the transition zone, because if you have a score of 3 in transition zone where I don't know, it has to be a fairly large volume diffusion change, meaning a diffusion of 5 for it to be upgraded to a 4. So this is where still some work needs to be done, but this is very helpful in the peripheral zone. So let's look at this. This is a very typical example, not great images. So this you can get, this is something that I want to show because, instead of showing very great normal nodules, I want to show you something like this. T2 weighted image with ill-defined area in the peripheral zone. ADC, my gosh, there's so much distortion, you can hardly see. This is an area that's maybe some dark area, but look at the lesion here. You can see something bright. DCE, little enhancement there. So let's see. Let's just score how we would do this. So where's this? Obviously, this is in the peripheral zone. And this is a sector map that's available also in the document. And this will nicely map where this lesion is located. And then you can see on PI-RADS, how would you define this as wedge-shaped, mildly hypointense lesion. So it's a 2. Let's look at the ADC. It's mildly hypointense on ADC, but it's bright on the high B value, and so it's a 3. So this is where it's a 3. So if you look at 3, then contrast comes in play, obviously. And so, is the contrast positive or not? And you can see focal enhancement. That's on the other side there, and this is focally enhancing area. So this is a positive. So that's how it got upgraded to a 4. So, and this was a 3+4 tumor on biopsy. So another example, 65-year-old with 3 negative biopsies, a high PSA, T2 weighted images. Again, not great T2 weighted images, but you can look that there's a lesion anteriorly. It's fairly large. It's greater than 1.5 centimeters, so it's a PI-RADS 5. Right away on T2, you can tell this. Diffusion is black and white, so that's also, and it's a large, so it's 5. This is no brainer. This was, a PI-RADS 5. So this is simple. Let's look at this. So 69-year-old, 2 negative biopsies and a PSA of 10. Now you look at the T2. This looks okay, like BPH. What about this area? This area looks a little ill-defined, and these are the problems. And when you first start looking at this, T2 in the transition zone can be problematic. And so when you look at this, what do? I think that's where the other images, if you have the coronal and sagittal, really can play a role. And here you can see that even though it looks ill-defined here on the coronal and sagittal, you can draw the margins. And so by default, because it's transition zone and in T2, it's a PI-RADS 2. And so on ADC, it's black and white. It's this would be considered a 4 on diffusion. And DC is focally positive, so that's but again, because it's in transition zone, this remains a 2. There are many clinical challenges. Okay, so the challenges are not just in PI-RADS, but just in imaging itself in prostate MR. And so I just wanted to highlight a few things, because once those challenges are done, that's where you can actually apply PI-RADS, because I found that to be some issues as well especially in training fellows and residents, I see that every day. For example, this is a 63-year-old man who has a PSA of 5. And he had Gleason score 6, and that was biopsied on a transrectal ultrasound, and he was referred to our institution for active surveillance. So 5% on the right base. That was the original biopsy. So as usual, when we enroll these men, we do an MRI, and when you look at this exam and the base, going back, I could not see anything in his peripheral zone, transition zone, anywhere. But when you look at his apex, there's a small area that looks slightly ill-defined, but let's focus on that. So if you look at this T2 weighted image, something is there. Yeah, ADC is a little dark here. Nothing on the high B value, but boom, look at this. DCE focally enhancing. So I find it's not just that DCE can help upgrade. I think detection, sometimes it may lead you to find the lesion as well. And so it's not just that it's a minor, and right now, because we don't have enough data for the pharmacokinetic modeling, it's a minor role, but we don't know in the future how that will play. So in this case, here's a lesion on T2. You would rate it as 3 out of 5 because it's focally defined, and diffusion will also be 3 out of 5. It's a positive DCE, so then it gets upgraded to a 4. This patient actually had distal apical extraprostatic extension. And of course, he had insignificant cancer in the base. That was all the reason he was enrolled for active surveillance. And he ended up having, his care was changed completely. He, on biopsy, had Gleason pattern 4, and he was obviously unsuitable for active surveillance. So this is a typical clinical scenario that can make a huge difference in someone's life. So now let's look at this. Where's the lesion? Don't really see it as well, but maybe something in here, but this is where you really have to use your other sequences and coronal image. So look at the coronal and sagittal. If you have either one, we get both, but some people only get one of the two. Look at them, because you'll find invariably it helps in the transition zone. It also helps in these small subcapsular crescentic tumors. And prostate cancer actually originates in the subcapsular region. So the early cancers are going to be there. Now, early doesn't mean necessarily it's going to be low grade. In this case, it was a 3+4 tumor, and it wasn't, it's hard to see it on the axial views. So how is PI-RADS doing with all this? So let me just go back actually in here. So the challenges are clinical. Obviously, detection is a big problem still, because there are tumors that hide in the apex. You can have extraprostatic extension in the apex, and you may not be able to see it on imaging as well. There are lesions that hide in the base, and so obviously understanding all of that is very important to really apply PI-RADS well. But even so, just in the past year, if you just do PubMed, you get over 300 articles. Not only in the radiology journal, urology, oncology, so this is all over the place. It's what I would call has gone viral on the internet. There are active blogs by patients and interest groups. I get referrals from physicians wanting to know the PI-RADS, and these are not academic physicians, so it's very impressive to see this. Nevertheless, let's see what the facts are actually. So if we look at one of the, so there's so many articles, I'm just going to concisely tell a few big ones. So this was a fairly big study, 425 patients, and the reference standard was prostatectomy, where they looked into PI-RADS version 2 and got just great sensitivity and specificity. And the best part was the inter-reader agreement. Kappa was 0.8, which was very good. And not only that, in the multivariate analysis, the PI-RADS version 2 category of lesions greater than or 4 were the only significant parameter for clinically significant cancer. So and this was the study, this was in 2016, and they looked at other things such as the biopsy Gleason score, greatest percentage of biopsy core, all of that, but all of that failed in front of the PI-RADS scoring in the multivariate analysis. And so that's very obviously encouraging to look at. Another study just published this year. This was larger. This was 4,000 patients, up to 4,000 patients, and they also looked at PI-RADS version 2, but the sensitivity and the pool sensitivity and specificity was 89% and 73%. One of the interesting part in this article is that there were highly variable negative predictive value for the exclusion of clinically significant prostate cancer. This is all over the place, 63 to 98%. Significant variability in the published results, some of the typical problems with meta-analysis, differences in patient population, reference standards, magnetic field strengths, obviously all of these. But what was interesting is that it did also subgroup analysis between PI-RADS 1 and 2, and I'll go over that in a second here. So the head-to-head analysis of PI-RADS 1 versus 2, this was the WU study that was just published this year. In that, if they do head-to-head analysis of 1 versus 2, there's significant improvement from PI-RADS 1 to 2. So sensitivity goes up to 95% and specificity is 75%. Specificity hasn't changed. But the idea is the sensitivity is markedly improved. Another meta-analysis of 2,000 some patients in 14 also showed improved sensitivity. In that study, they had meta-analysis, they found specificity was also improved. So, question is it a step in the right direction? I would have to agree with Dr. Armstrong, a humble scientist from University of Cincinnati. But anyway, I think it is, because it's an accepted global language. Now, if you learn any language to get fluent, you need to use it more, right? So you need practice, and you need just more time for it. And so that's what we don't have. This just came up in 2015, and we're, in the process of developing this. There's still data coming in, and I think everyone's beginning to speak the language in terms of standardization of image acquisition, interpretation, and reporting. And obviously, sensitivity is significantly better than PI-RADS 1. So there's no doubt about that. So the idea was standardization, and I think that is achieved. So in summary, obviously, there's still issues in PI-RADS, and this is already being worked on. This is already that focus group is looking into training and certification to reduce inter-observer variability. Add clinical scenarios such as active surveillance, which is not part of PI-RADS at this moment, recommendations for follow-up or biopsy. And again, the dreaded PI-RADS 3 transition zone, which overlaps with BPH, prostate cancer versus BPH. And the role of high B value in ADC will obviously, hopefully help in this region. It needs to be worked into. And I think quantification of diffusion-weighted imaging, because it is just very subjective to say hypo versus hyper-intense on the high B value images. Well, I may call it something moderate, and someone may say it very hyper, and so that you can change from 3 to 4 very easily in that. And I think that's where I think it'll make a big difference. Thank you.